Okay, can everybody hear me? Can you all hear me?
We've got you, Morgan. Thanks.
All right. So sorry, everybody. Technical difficulties. I'm from home today, and my Mac and work things did not want to cooperate together. So what we're going to do today is just talk a little bit about ketamine. First of all, happy EMS week. I don't want to forget that. You're all wonderful, and we appreciate everything you do. For those of you that don't know me, my name's Morgan. I'm one of the pharmacists in the emergency department at Maine Med. We're going to be talking about ketamine today. I know that there's a lot of kind of stigma around ketamine, and so we're going to just talk about maybe getting a little more familiar with it and when it's a great option to use, and we'll go from there. So I like to say, you know, the mitochondria is powerhouse of the cell. Well, ketamine is the powerhouse pre-hospital. So we're going to talk a little bit about how it works, why it works, how it compares to other agents, when to use it, when maybe not to use it, and how to safely use it. So we'll start a little bit with some pharmacology and mechanism stuff, because I am a pharmacist and we love that, and then move a little more into operational EMS type stuff, and if we have time, hopefully finish with some cases and decision making. The goal here is not protocol memorization. It's about improving kind of clinical decision-making skills for you guys out in the field. So let's go through some basics about ketamine. So why are we talking about ketamine? So in a lot of EMS situations, we need something that is fast, reliable, safe, something that works, whether it's pain, agitation, or both. And that's where ketamine kind of comes in. So the more you understand how ketamine works, the better your decisions become in those moments. So ketamine's a really unique drug because it can function in multiple clinical roles differently. So depending on the dose and situation, ketamine can provide analgesia, dissociation, sedation, procedural support, which I know you guys won't necessarily be doing, but it's an option, and behavioral control, all while avoiding some of those adverse effects that may limit some other medications. So there's not very many medications in EMS practice that have kind of that level of versatility. So the goal today, I'll preface all of this by saying it's not to force anyone to use ketamine all the time. It's just to go over what you can expect to see when you do use it, so you're more comfortable using it in a scenario where it might prove to be really helpful for that patient. So just a little history about ketamine. In the 1950s, researchers were searching for better anesthetic and analgesic agents. So PCP, or phencyclidine, was developed as a promising option. So it provided strong pain control and anesthesia. Despite being effective, it also had a lot of significant adverse effects and poor muscle relaxation that made it not super great in clinical use. So in 1962, a chemist synthesized ketamine as a safer alternative to PCP. So early human studies in 1964 showed that ketamine acted faster and produced fewer of those severe adverse effects, leading to it becoming classified as a dissociative anesthetic. Moving into the 70s, there were some clinical trials done that showed ketamine was effective as an analgesic and anesthetic. They did note hallucinations and emergence reactions as some of the notable side effects, and we'll talk about that in a little bit. But despite those side effects, the FDA approved ketamine for medical use, and it became really popular during wartime, so the Vietnam War, for battlefield anesthesia, for rapid dissociative anesthesia, reliability, and its relative respiratory and hemodynamic stability. So it was especially useful in combat situations where advanced monitoring and airway equipment were limited. So as ketamine's medical use expanded, unfortunately, so did its recreational misuse in the 80s and 90s that eventually led to it becoming a federally controlled substance in 1999, but not before the World Health Organization added it to the list of essential medicines in 1985. And then moving forward kind of closer in time, more recently, ketamine has seen a pretty major resurgence in medicine. So research has highlighted its rapid antidepressant effects in treatment-resistant depression, along with some potential roles in anxiety, PTSD, chronic pain, neuropathic pain. And then it's being used in a wide range of settings for analgesia, dissociative sedation, anesthesia, and behavioral emergencies, which including the EMS scene, which is what we're going to be focusing on today. So we'll run through the next couple slides pretty quickly because I know that organic chemistry is a love of mine, but not everybody else's. So in case you're wondering what the fancy name for ketamine is, it's up there. I'm not going to make anyone say it or me say it, but it is structurally very similar to PCP. So you can see based on the two structures that only mild differences exist between the two. So a little bit, because I just can't not. So stereoisomers are something in chemistry where atoms are bound to each other by the same number of bonds. So it'll have the same molecular formula, but different spatial arrangements. So those can either be diastereomers or enantiomers, and they're either going to be not mirror images or mirror images of each other. So if you were to look at your hands in front of you, all your fingers are connected the same way and are mirror images of each other. They can't be superimposed, meaning if you put one on top of the other, they're not going to be the exact same. Even if you flip one hand over and put the other on top of the other, your fingers still bend in different directions, which in this case represents different 3D orientations of chemical structures. So in chemical compounds, it's kind of like the handedness of a chemical compound, and there's either an R or an S compound. So keeping that in mind, every chemical compound is a 3D structure of some kind. And the reason that that matters is different enantiomers of different drugs can produce different clinical effects because they interact differently with different 3D receptors and enzymes and transport proteins in the body, which can lead to differences in potency, onset, duration, adverse effects, receptor selectivity, abuse potential, all of those types of things. So the same molecule on paper doesn't always mean that it has the same effects in the body. So it's kind of like putting on a glove. You could probably put a left-handed glove onto a right hand and it would still work, but it wouldn't feel quite right and it might not function the way that the correct glove would. So the reason that this comes into play with ketamine is drugs that are marketed as racemic mixtures, which I'm sure all of you have heard, is a combination of both enantiomers of a drug. So most ketamine is marketed as a racemic mixture, which means it has equal amounts of the R and S compound in it. And we'll talk about how that kind of affects the drug in a few minutes when we talk about how it works. And there's different products on the market that are different combinations of this R and S type compound. So another classic example is albuterol. So the R albuterol is an active bronchodilator. The S-albuterol is less useful and has some of those side effects that we don't want. So things like levalbuterol is that purified R enantiomer of albuterol. So it can have some effects. So see, organic chemistry it's fun. It's not terrible. All right. So neurotransmission. So neurotransmitters are the keys that unlock neighboring neurons and allow different downstream effects, whether that be voltage changes or allowing different ions to flow in and out of a cell. So today we're going to be talking about glutamate, which is the excitatory neurotransmitter, and specifically in relation to the NMDA receptor. I could spend literally hours talking about the AMPA receptors and all these other activities in regards to ketamine, but that's more of a longer term benefit where we're going to see treatment resistant depression and things like that come in. But today we're going to talk about what you guys will kind of be utilizing is that NMDA receptor. So an NMDA receptor, again, like we just said, primary neurotransmitter is glutamate. And it kind of works as the on switch for brain activity. So you have excitatory neurotransmission. It has to do with memory function, learning, brain development, consciousness integration, pain signaling for both acute and chronic pain, as well as synaptic plasticity, which is basically your brain's ability to strengthen, weaken, or reorganize connections between neurons over time. And that comes in a little more with some of the other types of clinical indications for ketamine. So what is ketamine specifically? It's classed as a dissociative anesthetic. So NMDA receptor antagonist is the type of drug that it is, which means it blocks the receptor and inhibits activity, affecting neurotransmission. And that is critical to the anesthetic and analgesic effects of ketamine. So NMDA receptors allow sodium and calcium ions in and out of the cell, as well as a little potassium exchange, and that increases the probability that the neuron's going to fire. So ketamine acts as an intracellular kind of ion or molecule that acts on the pore portion, and it results in decreased opening time and less calcium flow, so the neuron doesn't fire. So it decreases sensory input to higher areas of the CNS, such as emotional responses in that kind of learning and memory, and effects on functional dissociation pathways and pain perception, which is why we're going to be using it. So what is functional dissociation? So functional dissociation is that separation between sensory input and conscious awareness. So basically it disrupts communication between areas of the brain, specifically the thalamus and the cerebral cortex. So the brain is receiving signals, but the person's no longer fully processing or responding to them normally. So pain signals are not fully perceived, awareness of surroundings becomes disconnected. The ketamine doesn't completely shut the brain down like some other anesthetics, such as propofol, but it does disconnect the brain from fully processing the environment. So patients can still appear awake, but they're not fully aware or responsive. They could keep their eyes open, they can still move sometimes, maintain respirations, and they're kind of preserving their airway reflexes, but they're still not feeling pain, remembering events, and not interacting meaningfully in the environment. In terms of pain perception, the analgesic mechanism of ketamine is a complex combination of multiple different factors. So over here, you can kind of see the glutamate release and nociceptive neurons on the dorsal horn of the spinal cord. So basically, at low doses, analgesia effects of ketamine are mediated by that antagonism of the NMDA receptor, which causes an interruption in abnormal or in pain signaling, reduces amplification of pain. It can have effects on the chronic pain pathway. And evidence of this kind of mechanism for pain is reinforced by the fact that naloxone, an opioid antagonist, does not reverse the analgesic properties of ketamine. So we'll talk in a few minutes about opioid pathway and anti-inflammatory mediation, but the primary mechanism is NMDA receptor antagonism. So while that NMDA receptor is the primary mechanism, there's also a couple different things that ketamine interacts with and other systems that play a role in its clinical activity. So the opioid pathways for analgesia, catecholamine systems and sympathetic responses, the muscarinic systems, and some inflammatory pathway mediation. So jumping into the opioid pathways, so ketamine does have a mild interaction with opioid receptors, so mu, kappa, and delta. Again, this is not its primary mechanism, but it still exists. It reduces opioid tolerance. So NMDA activation contributes to opioid tolerance and opioid-induced hyperalgesia. So by blocking that NMDA receptor, you can restore opioid sensitivity, reduce escalating opioid needs, and reduce hyperalgesia. It also can have a opioid sparing effect, meaning you can achieve pain control with lower doses of opioids, and you can have less of those side effects like respiratory depression and hypotension. So enhancing pain control, reducing opioid requirements, and improving opioid effectiveness. This is really helpful in trauma patients when you have those patients that fentanyl isn't touching the pain, opioids are causing respiratory concerns, the patients are on an opioid antagonist or they're opioid tolerant, and the patient has pain that's severe and multifactorial. So just keeping in mind that ketamine doesn't replace opioids, but it does change how the nervous system processes pain and can make opioids work better. All right, probably the most common one that everyone might be familiar with is this catecholamine system effect. So ketamine can stimulate the sympathetic nervous system, which means it increases circulating catecholamines, norepinephrine and epinephrine, by increasing their release and reducing their reuptake into the neuron. So physiologic effects that you'll see with that are increased heart rate, blood pressure, and cardiac output. It can be helpful in a lot of situations. So in trauma patients, in hypotensive patients, different shock states, and hemodynamically unstable patients. So when we talk about shock index, that's why in kind of trauma questioning, it's highest heart rate, lowest blood pressure. So heart rate over systolic blood pressure gives you this shock index. So normal values, a shock index less than 0.7 is no shock. And then there's mild shock, moderate shock, and severe shock going up over a shock index of 1.4. So just something to keep in mind in when we're talking about shock states in patients that number is kind of over 1.4 or severe shock. Those patients can be catecholamine depleted. So yes, catecholamine releases this kind of natural stress state that releases catecholamines. But if a patient is really critically ill, severely septic, in really advanced stages of shock, their body may have already depleted these stores. So just something to keep in mind that you can still use it, but ketamine you can have myocardial depression and subsequent hypotension in those patients because there's no catecholamines left in those patients to kind of offset any hypotensive effects. So just something to keep in mind in those really, really severe high shock index patients. Things that can be potentially harmful because of these effects, tachycardia, hypertensive patients, patients with an acute MI, severe hypertension, significant cardiovascular diseases, all these things that are going to have kind of this increased myocardial oxygen demand. So while ketamine can offer blood pressure support instead of lowering it, sometimes that sympathetic stimulation is not always beneficial. All right. So the muscarinic system. So mild anti-muscarinic effects interfere with the acetylcholine activity in the parasympathetic nervous system. So when you think parasympathetic nervous system, that's usually your rest and digest type systems. So you can have bronchodilation, reduced airway, smooth muscle constriction. While it may open the airways, it can also make them wetter, so increased salivary and airway secretions. So while most airway protection is maintained, it's important to keep in mind that you may have increased suctioning needs, you may have some airway management challenges, and there is a rare laryngospasm risk that we'll talk about in a second. Airway preparation and protection remains critical, especially in pediatric patients, severe agitation, or where you're going to be using a lot higher doses for that kind of dissociative sedation that we'll talk about in a second. And then lastly, inflammatory pathways. So like we said, ketamine affects far more than sedation. It also has influence on pain in more kind of downstream inflammatory signaling pathways. So anti-inflammatory and immunomodulatory effects, so suppression of inflammatory pro-inflammatory cytokines like TNF and interleukins, again, reduce neuroinflammation, decrease central sensitization, which is kind of when the nervous system becomes overly sensitive to pain signals over time. So these effects are not why EMS is going to be using ketamine acutely, but they can help, just something to be aware of, that they can help explain some of that opioid sparing effect. They can be beneficial in difficult pain syndromes like chronic pain and neuropathic pain, and also where some of the interest in mental health applications like depression, PTSD, and critical illnesses come into play. So just one more second on the organic chemistry type piece. So this is just a comparative table. I'm not going to spend a lot of time on here. The difference between S and R ketamine and where we might see it in clinical practice in the future, or even technically right now. So R and S stereoisomers of ketamine have different binding affinities, which means they have different pain and anesthetic potencies, but similar kinetics. So the S form seems to be has a 4-time greater affinity for the PCP site of an NMDA receptor than the R ketamine. So in terms of clinical utility, that S form seems to be better at inducing the drowsiness and dissociative properties than the R form is. It's also, because it's vastly more potent at blocking that receptor, it's responsible for the heavy lifting when it comes to surgical anesthesia, rapid pain relief, and immediate dissociation. So that R ketamine kind of side, where it's a little less active at that NMDA receptor, is where it's being heavily researched for its unique ability to promote brain plasticity, provide longer lasting antidepressant effects without having kind of that heavy dissociative high type effect. A lot of clinicians and researchers believe that a balance is a great thing, and 50-50 kind of racemic mixtures work great and work synergistically together. So by combining the R and S formulations, we get this kind of immediate therapeutic anesthetic action, and then have some supporting downstream signaling and neuroplasticity type benefits, which is why standard formulations of ketamine and what you guys will be using is a racemic mixture of the two. Okay, moving into, great, okay, ketamine, how it's applied. So I know that in the EMS, I think Joe's box will have the 10 milligram per ml, 200 milligram vials. What you guys have, I believe, is the 500 milligram per 5 ml vial, or the 100 milligram per ml concentrated, which is usually used for IM administration. If it's going to be given IV, usually it'll be diluted, I believe, in your protocols, which we'll go over in a second, are diluted in 100 mLs of saline. But the undiluted can be given as slow IV push over 1 to 2 minutes. IM into a large muscle, and just making sure that it is a large muscle, because most patients, because there's higher dosing for IM administration, most patients are going to end up in that 3 to 4 ml range. So we don't want to be putting that into small muscle areas. All right. So route selection matters significantly in EMS. So looking at just some of the differences between pharmacokinetics of the different routes. So onset, as we move from IV to IM to intranasal, it gets a little longer. So onset 30 seconds with IV, 3 to 4 minutes with IM, and 5 to 10 minutes with intranasal. Duration alters significantly between them as well. So duration for IV about 10 to 15 minutes with recovery in about 1 to 2 hours. IM 12 to 25 minutes with recovery a little longer in that 3 to 4 hour range. And then intranasal is variable. So 30 to 60 minutes, but everybody's a little different. And recovery 1 to 2 hours, but again, variable. So things to overall for EMS consideration. So IV is going to be the fastest onset, easiest titration, and fastest recovery. IM ketamine, super useful when maybe IV access is unsafe or unrealistic in whatever setting you're in. Violent or severely agitated patients, slower onset, but it is highly reliable. So that's something to keep in mind. Intranasal ketamine, again, valuable for pain management, useful in peds, avoids IV placement, but it does have slower and less predictable pharmacokinetics. Other things to just keep in mind, you will need an atomizer, or in most cases for use of intranasal. Bitter taste, intranasal volume, those are things that can kind of limit those routes as well. Operational context matters, right? So ultimately, the best medication route is the one that you can realistically and safely deliver to your patient. So pharmacodynamics, a little bit about the drug. So ketamine it's a high lipid solubility, so it has really high CNS penetration. So it readily crosses the blood-brain barrier and doesn't require a lipid solvent, like some other drugs like propofol, how it's in that lipid emulsion. Ketamine kind of does that on its own. And that's why you can have those profound analgesic effects at sub-anesthetic dosing, because it so readily enters the blood-brain barrier. In terms of metabolism, mainly what I want you guys to be aware of is that it does get metabolized by the liver and has an active metabolite called norketamine. So point being that norketamine still has sedative and analgesic activity. It's thought to be about 20% of the activity that ketamine itself has. So that is especially relevant for larger doses or infusions. So just keep in mind that in patients with liver dysfunction or things like that, they may have prolonged effects based on metabolism and that active metabolite. Some other things to keep in mind, just as we kind of just talked about lipid solubility and things like that. So if it can enter tissue quickly, it can leave tissue quickly. So in terms of redistribution, so it has a short duration after IV dosing, mainly due to redistribution. So it wears out quickly because it comes back out of the brain, not necessarily because the body immediately eliminates it. But that is the reason why you can have rapid recovery. Also, where you might have to start considering the need for repeat dosing during long transports or procedures. And then when we flip over kind of into the IM administration, you can have effects that last longer because it has a longer duration, which means delayed recovery. It's also harder to titrate. So just kind of approaching redosing a little more cautiously. Okay, and then clinical effect spectrum. So ketamine is not a single use medication. It exists on a spectrum and the dose determines the effect. So kind of as we move through dosing with low dosing, primarily for analgesia, reduced opioid requirements, and it preserves kind of interaction with the patient. That's what we would refer to as that sub-dissociative dose or sub-anesthetic dosing. As we move into moderate dosing, so useful for severe agitation, scene control, it has that kind of production of dissociation type effects. And then in the hospital, we'll use it as procedural sedation as well. And then higher doses is where we move into that kind of deep sedation category. So deeper sedation, but that's also where you need to be thinking more intensive monitoring, as you may have things like airway risks. So we'll look a little more at dosing when we talk about the protocols, but just kind of being familiar with the general trend of dosing of low to high being sub-dissociative up to deep sedation. Okay. So let's move into some safety stuff. So a lot of the side effect profile is expected based on how we know the drug works and what effects it has on different receptors and systems. Something to keep in mind, every drug has side effects. So I don't want everyone to be scared of ketamine. I think it gets a bad rep due to unfamiliarity, but most side effects are transient and self-limited and don't actually require intervention or rescue. So really, I just want you guys to be aware of what to expect and what could potentially happen and how to kind of mitigate those risks. So let's just go by system here. So cardiovascular effects. So kind of as we discussed earlier, you have that catecholamine release that occurs that leads to an increase in sympathetic nervous system outflow. So tachycardia, you can have an increase in heart rate thought to be about 10 to 20% on average. Same thing, hypertension. So systolic rises about 20 to 30 and diastolics about 5 to 10. With the blood pressure, you'll usually see a steady rise over 3 to 5 minutes, but it usually returns to normal about 10 to 20 minutes after injections. The point just being that you need to be aware that they may have an increased workload of the heart. So what you want to kind of be managing is anticipating that before you're giving somebody ketamine. So monitoring their blood pressure, their heart rate, SpO2s and end tidals if it's available, but avoiding stacking kind of stimulatory stressors when possible. So ketamine should be, for example, ketamine should be avoided if cocaine use is suspected. So sympathomimetic effects may potentiate the cardiovascular toxicity of somebody that has been using cocaine. Things like that, just to know that that's something that's coming. Treating pain and agitation, but just reassessing frequently with those vitals to make sure you're still within a normal range. Okay, moving to respiratory. Great. Okay, so when ketamine produces bronchodilating type effects, it makes it useful for patients that have asthma, but it can also have some side effects that go along with that antimuscarinic type rest and digest pathway activity. So increased salivary and airway secretions. You can also have transient apnea that happens with a rapid IV injection. So that's why in the protocols, you'll see that ketamine should be administered slowly over 1 minute or more, unless it's being used for RSI, which is a completely different type scenario. Laryngospasm is also a respiratory complication, and we'll talk about that on the next slide. So risk management, simple O2 masks, nasal cannulas, continuous pulse ox, end titles when available. Have your airway equipment ready, knowing that it is a risk, having suction available, and just making sure that you're using ongoing assessment after administration. Things to keep in mind with patients. So sedative effects of alcohol, sedative effects of benzodiazepines. You can have a higher risk for respiratory decompensation when you're using ketamine or in those patients. So just making sure that you have advanced airway stuff ready in case those situations arise in those patients. So laryngospasm specifically, frightening. It's an involuntary muscle spasm of the vocal cords that temporarily blocks your airway. So it's uncommon, but it's important because it is a high risk thing. So it's more common with rapid IV administration. It's more common in pediatrics. Things that you can look for, so stridor, airway movement difficulty, if they're desatting. It isn't super common, so it's thought to be about 4.2 out of 1,000 or 0.42% of cases. So it doesn't happen a lot. But the biggest thing you can do, the first step in management, is to be prepared for it. So having suction, a bag valve mask, have it ready, have advanced airway equipment in the room, and use your monitoring for early signs of laryngospasm or hypoventilation. For step 2, I guess, would be open the airway. Basics are best, right? So the airway may be obstructed, but you may not be encountering actual laryngospasm. So if it's not, optimizing position of the patient will likely correct the problem. Align and open the airway, and anticipating the challenges inherently in children's airways is also going to be important. The next thing you would do, applying pressure to the laryngospasm notch, or Larson's point, Larson's notch, whatever you may kind of be familiar with hearing it as. So behind the earlobes, in front of the mastoid process, and pushing hard. So a lot of people will say it's like a jaw thrust, but a little meaner. So doing this may avoid needing additional therapy. But at this point, if you're doing this, it might not be a bad idea to have someone getting a BVM and airway equipment ready. That's not a terrible idea. Step 4 would be positive air pressure ventilation. So in combination with the pressure on the notch, that should resolve the issue. In really rare instances, that's when we would have to move into RSI. Intubation may be necessary, but that's less than 5% of laryngospasm cases that end up requiring intubation. So you shouldn't fear ketamine unnecessarily, but you should have a healthy respect for airway complications and just be prepared for intervention if that does happen. Okay. Moving along the same antimuscarinic kind of rest and digest type pathway. So nausea, vomiting, hypersalivation. Vomiting is more frequent with IM dosing. It also has a greater risk in early adolescence. So these side effects can have an increased risk for aspiration, airway contamination, and difficulty tolerating CPAPs or BiPAPs. So even though it seems like a GI effect, it just might have some downstream effects that you should be aware of. Higher risk type situations, again, higher dissociative doses, pediatric patients, and co-administration with other sedatives. Things for risk management, be prepared for increased secretion, so suction readily available, positioning the patient, monitoring their airway closely, and if protocol allows, administering antiemetics. Okay. Neurologic and psychologic type effects. So dizziness, confusion, disorientation, hallucinations, nystagmus, so that kind of shaking of the eyes, increased muscle tone, and emergence reactions, which we'll talk about on the next slide. The higher risk of these is when patients are in the recovery phase. If you're using higher dissociative doses, adult patients, and if you're in really stimulating kind of chaotic environments, which makes sense. Risk management, so calm, low stimulation environments, frequent reassessments, verbal reassurance during recovery, and then benzodiazepines we'll talk about here on this next slide. So emergence reactions are kind of what people describe as that wake-up experience. So you can have vivid, unpleasant dreams, excitement, confusion, fear, and it may come across as severe anxiety, confusion, hallucinations, and agitation during recovery. So it usually happens in that first hour of emergence, and usually tends to go away in 1 to 3 hours afterwards. So next we'll go to, so step 1, similar to the other, there we go. Supportive care, so reducing sensory input, turning down the lights, minimizing noise, limiting physical commotion, verbal reassurance, so gently, calmly reorienting the patient to their surroundings. In terms of prevention, slow administration, so it's more common with rapid IV administration, so giving ketamine slower. If you're giving it IV, the protocol has you guys doing an infusion anyway, so that it should kind of help get rid of some of that. Pre-treatment, I have this grayed out. Some providers can occasionally pre-medicate or co-administer small doses of midazolam or benzodiazepines. that prophylactic use is not universally recommended. So that's not something that I'm going to put up here. But the last step would be benzodiazepines. So midazolam or diazepam are kind of that gold standard for rapidly treating and blunting hyperactive delirium and severe emergence reactions post-ketamine. All right, and then, so just general safety considerations that kind of are grouped into all of them: cardiac monitoring, continuous pulse ox, end tidal when available, airway readiness, and just reassessment documentation. Most of these adverse effects, again, like I said kind of at the beginning, are manageable when you anticipate them, you recognize them early, and you're prepared for them. When using ketamine, so it's not just all about pharmacology, it's also operational type stuff. So scene coordination matters, communication matters, monitoring during movement and transport matters, and documentation matters. So those are all things that you guys should be keeping in mind also. In terms of contraindications, there used to be a much larger list of contraindications surrounding the use of ketamine, but a lot of the studies have found that the risks are actually a lot lower than originally anticipated. So that led to few actual contraindications. So known hypersensitivity to the drug, which is kind of a no-brainer. Use of ketamine in children less than 3 months of age. That's due to a higher incidence of airway complications and can lead to laryngospasm. And then contraindicated in those who have significant elevations in blood pressure that would constitute a serious hazard. So kind of from that sympathetic outflow that we talked about a little earlier. All right, let's talk about some myths. I didn't have my slides work, but there was some animation on this slide and everything. So common myths: ketamine stops breathing. Ketamine actually preserves respiratory drive better than most other sedatives and usually has bronchodilatory type effects. So it's still important to note that it doesn't guarantee airway safety. There are still risks, but definitely that ketamine stops breathing is not accurate. Ketamine is only for excited delirium. That is also not accurate. It has dose-dependent spectrum of clinical effects, including analgesia, dissociation, sedation, anesthesia. So it has all kinds of things. Very versatile. It's a great drug. One of the most common ones is ketamine increases intracranial pressure and is unsafe in head injury. So ketamine can safely be administered to head injury trauma patients. It actually has minimal effects on intracranial pressure and has no adverse effects when it comes to cerebral perfusion pressure or neurologic outcomes. So traditionally, it was thought to increase intracranial pressure, so it was contraindicated in TBIs. New evidence suggests that that's actually not clinically significant in terms of ICP increases. There was a big meta-analysis that was done over 900 trauma patients back in 2015 that showed no difference in CPPs or any patient-centered outcomes. So that's actually not a contraindication. And while it's not a contraindication, it's just important to keep in mind that it does induce a dissociative type state. So it might not be a bad idea to get a GCS documented prior to administration if you do have a head injury patient. And then the last one, ketamine's unsafe in eye injuries. So this one was based on a lot of reports that were in the 60s and 70s. So ketamine-induced changes in intraocular pressure are really slight, and they're not clinically significant. A lot of the increases in IOP were in doses that were 5-6 mg per kg, and the changes that were seen in the studies were mild in the 1 to 3 millimeters of mercury type range, which is actually similar to the rise that was seen in subjects who were just having an eye exam performed, similar to what you would see with like white coat syndrome. So tactical combat casualty care guidelines don't actually preclude the use of ketamine in known or suspected open globe injuries. The one thing to keep in mind is that you shouldn't be using it for procedural sedation. Not that that's something you guys would be doing in the field, but for eye exams because of one of the side effects of nystagmus. That wouldn't be helpful in an eye exam. Okay, just a couple special population things. Pregnancy. So there's a lot of mixed data on neurotoxicity of prenatal ketamine. A lot of the studies are done using repeated dosing. So data on single dose EMS administration is really limited. In general, not recommended as a first line just because there's such limited information about it. But use when benefit outweighs the risk would just result in making sure you're monitoring maternal hemodynamics. But in general, it's not going to be the first thing that we grab for pregnant women. In the elderly, they're more sensitive to sedative type effects, so higher risks of confusion, emergence reactions, so considering lower dosing strategies in those patients. Psychiatric illnesses, just being aware that while it's not a contraindication necessarily in active psychosis or schizophrenia, especially in trauma patients with schizophrenia, those emergence type reactions and hallucinations might be more distressing to those patients. So just being aware that is a risk also. In pediatrics, things to keep in mind. It's great for painful procedures. It has an intranasal route, which comes in really handy with peds, but just keeping in mind that it does have a higher laryngospasm risk in that pediatric population. In traumas, it can be really helpful for hypotension and severe pain. And then asthma, it has that bronchodilation advantage that we'll talk about a little moving forward in cases. Okay. So now that we've talked a lot about how ketamine works, how it's administered, some of the side effects, what to expect, let's just take a quick look. We're going to probably go through this really quickly on EMS protocols that utilize ketamine as an option. So we'll compare ketamine to other options that are available in those scenarios and talk through kind of some of the steps you can use to your advantage to help choose the best medication for a given scenario. Okay, so when using, let's start with pain, because that's going to be probably the most common indication you guys are going to be seeing. So potential indications: severe trauma, pain, burn injuries, fractures, opioid tolerant patients, and hypotensive pain patients. So advantages of ketamine in general in analgesic uses is opioid sparing effects, preserving blood pressure, preserving respirations, and multiple routes of administration that are available. Okay, so this is just a screenshot of what is in the actual protocol, the Universal Pain Control and Stable Patients Screen 19, I think is what it is officially. So for pain control, it usually starts with Tylenol, and then controlled pain can move into fentanyl or ketamine. Or nitrous oxide. Admittedly, I didn't realize until this morning that some of you still have access to nitrous oxide and use it. So I didn't actually talk about it in this presentation because I didn't know that you had it. But that's exciting for those of you that do. That's commonly known as laughing gas for anybody that doesn't use it. So fentanyl, the options are either 1 mic per kilo, IVIM, or intranasal, or your ketamine options are 0.2 mg per kg IV or 0.5 mg per kg intranasally. So again, those lower doses of ketamine is what we're going to be using for pain control. And then, all right, so Joe, the next. So ketamine versus fentanyl for pain control, just where kind of our decision tree comes in. So this isn't about necessarily one medication being universally superior. It's about choosing the right medication for the patient and the environment in that very given situation. So one of the key or some of the key differences when choosing one versus the other, that's usually what's noted in the actual protocol on that orange kind of pearls box that you'll see. It was on the last slide, but that's kind of what it's highlighting here. So major hemodynamic differences. So ketamine usually preserves or increases blood pressure, where you might see some hypotensive effects in fentanyl. In terms of respiratory depression effects with ketamine, that's going to be minimal in most patients, where that is a possible effect that you'll see with fentanyl. Both of them are great for pain. Sedation, dissociative type effects. So ketamine is going to have possible dissociation, or if you're going for it, obviously with much higher doses, but on the higher end, possible sedation type dissociation effects, where that's going to be relatively minimal with ketamine. So when it comes to fentanyl versus ketamine and what situations one might be preferred in. So when fentanyl might be preferred are things like stable isolated pain, calmer patients, when you need mild, moderate pain requiring titration, if you need to avoid dissociation, if you have concerns for emergence reactions, or if you're in a calm, controlled transport type environment. Situations where ketamine might be preferred for pain: in a hypotensive trauma patient, for really severe pain that might be accompanied by some agitation, difficult IV access, if a patient's opioid tolerant, if they're a high-risk respiratory patient, or you need a really reliable IM option for an uncontrolled type scene. And then this is just what is available to you guys for ketamine. So 0.2 mg per kg IV, again, in that 100 mLs over 10 minutes to try to combat some of those side effects with the rapid IV titrations or infusions, and 0.5 mg per kg intranasally. Okay, moving into ketamine for sedation. So common things that we're going to see: severe agitation, hyperactive delirium, violent behavior, procedural sedations, not as much on the outpatient side, but it is available, and rescue sedations. So operational goals for EMS is usually in these cases going to be rapid control, patient safety, responder safety, and just using kind of some of that physiology, preserving physiology. So the hyperactive delirium with severe agitation, or Orange 6 protocol for you guys. So for patients that have an altered mental status score of +4 or above 4, we're going to be moving kind of into this sedation territory. So your options are going to be, for adults, midazolam 4 to 10 milligrams IM, peds 0.1 mg per kg IM with a max of 10 milligrams. And then your ketamine options are 4 mg per kg IM with a max of 500 milligrams for adults. Again, that's going to be using that 100 milligram per ml concentration to make sure that it's not an outrageously large volume. We'll talk about it a little bit on the next slide, but I just highlighted this kind of orange pearls section of the protocol. So patients with underlying medical conditions, including COPD, CHF, coronary artery disease, as well as patients older than 60 are more likely to suffer adverse effects from midazolam, so considering using lower doses in that population. It also talks about respiratory depression and sedation with midazolam. So those are things that we're going to see here kind of on this next few slides. So when we're looking at ketamine versus midazolam for sedation and anxiolysis, so both of them have relatively quick onset, are available IV and IM. For ketamine, in terms of reliability in severe agitation cases, ketamine is more reliable. Midazolam is less reliable in terms of it being monotherapy. So that's something to keep in mind. For respiratory effects, ketamine will usually preserve that respiratory drive, where midazolam, respiratory depression is possible. As well as in the hemodynamic side of things, ketamine will preserve and increase blood pressure in most cases, where midazolam may lower blood pressure. Another thing that's really important to keep in mind that I didn't put a yellow square over analgesia. So midazolam doesn't have any sort of analgesic properties where ketamine does, and that's something that this combination utilization of ketamine is really great for. So when it comes to when one might be preferred over the other, so when midazolam might be preferred, so anxiety, panic without severe agitation, in mild to moderate agitation, patients that have seizure activity, if you need anxiolysis rather than dissociation as an adjunct for emergence reactions, and patients who are already improving with verbal de-escalation. In patients that ketamine may be preferred, so violent or severely combative patients, if you need rapid scene control, severe agitation, difficult IV access, higher concern for respiratory depression, so similar to what we kind of saw on that orange pearls section, patients that have underlying respiratory conditions, and a need for dissociative sedation rather than kind of that simple anxiolytic type calming effect. And this is just the dosing that's available to you guys. So under 65 for adults, 4 mg per kg to a max of 500. And over 65, we're not going to be using ketamine. For pediatric dosing, same thing, 4 mg per kg. If they're under 50 kilos, it'll max out at 200 milligrams. All right. And then these next few, we're going to move through pretty quickly because they're very similar. So anxiolysis and CPAP. So for you guys in EMS, the use is usually things like severe COPD exacerbations, flash pulmonedema, patients struggling to tolerate non-invasive ventilations. What are these patients going to be feeling? Why are we using this anxiolysis? So anxiety, panic, claustrophobia, agitation, feeling of air hunger, all these things are what we can see when patients are on CPAP. So your options are going to be midazolam, some of that lower dosing, 0.5 to 2.5 milligrams IV or IO, or 1 to 5 IM. And then ketamine, 0.2 mg per kg IV IO, and 0.4 milligrams per kilogram IM. So for these indications, we're going to be using a lot of the same concepts here, but it's on a kind of lower, lesser scale. So in the lower doses of these medications, where risks are a little lower, some of the differences might be a little more subtle, and this might be where you start looking at the patient as a whole, maybe some past medical history. Is pain also maybe an issue here and not resolved completely? So in those cases, when ketamine may help, so preserving respiratory drive, it maintains airway reflexes with minimal respiratory depression. It has that bronchodilation benefit and may improve mask tolerance. Important things just to consider: if the goal is anxiolysis and cooperation, you're not looking for dissociation. We're using these lower dosing strategies here. Continuous monitoring is still required even when you're using lower dosing strategies, because the risks of the medications are still there. If you're going to use ketamine, just being prepared for secretions and vomiting. So depending on the patient, if you have a patient with a lot of secretions, ketamine might not be the best option as an anxiolytic for CPAP. And why don't we just use midazolam? Again, that suppression in respiratory drive, you can worsen hypercapnia and cause hypoventilation in fragile respiratory patients that you'll be kind of putting on this CPAP. So in patients dependent on respiratory drive, ketamine can improve CPAP tolerance without significantly worsening ventilation and any sort of drive that they have. Again, this is kind of your options that are in your protocol. So 0.2 mg per kg IV IO, or that 0.4 mg per kg IM. And then just moving quickly through this next one is post-intubation, airway device control and sedation with anxiolysis. So after you've controlled pain, because a lot of times that's kind of step one, and a lot of that anxiety will relieve after pain, you do have those exact same options with midazolam, 0.5 to 2.5 IV and IO, as well as in that pediatric population, and then ketamine, 0.2 mg per kg IV and IO, as well as 0.4 mg per kg IM. Okay, and then the last thing that's in your guys' protocol is that pre-hospital management of hospice patients. I don't believe this comes up a whole lot for you guys, but just being familiar that it is there. It is one that you would have to call med control for, but for those hospice patients on transport with anxiety, you do have that option of ketamine, 0.5 mg per kg intranasal with a max of 25 milligrams. Okay. And then just really quickly, we're going to rapid fire through a couple case-based applications. So now that we've kind of talked about what's available to you, when you can use it, we're just going to look at some of the options given specific cases and why one might have advantages over the other. Again, in a lot of these cases, there's no completely black and white right or wrong answer. They are both options, but just some things to pick up on patient cases that might help you decide between one or the other. Okay, so if you have a hypotensive trauma, so a 24-year-old high-speed MVC, you arrive on scene and find that the patient's alert and obvious distress, screaming in pain, repeatedly grabbing his right leg. There's an open femur fracture with deformity that's obvious. The patient's pale, cool, diaphoretic. Looking at their BP, we're in the 80s over 50s with a 10 out of 10 pain. And you have about a 20-minute transport time to the hospital. What might you be thinking of in terms of your analgesic choice between fentanyl and ketamine? So in this particular case, we can move to the next slide, Joe. Okay. So advantages that you might have with ketamine. So preserving that blood pressure, again, in the 80s over 50s, this might have some benefit here, maintaining respiratory drive, awesome for analgesia and trauma patients, and any sort of potential hemorrhagic patients, it can be beneficial in. Fentanyl in this case, it may worsen that hypotension, and it may have some respiratory suppression in unstable traumas. Again, we don't know exactly how bad the effect of the trauma is here. Case 2, a stable orthopedic injury. So EMS is called for someone who slipped while hiking, calmly sitting on the ground. They have severe pain with movement that has an obvious ankle deformity, but still has strong distal pulses. Vitals look okay. The patient's calm, cooperative, answering questions appropriately, and you have about 10 minutes of transport to get to the hospital. So in this particular case, fentanyl might have some great advantages, being a great first-line option. So excellent isolated pain control, rapid titration, familiar side effect profiles, and have less of any type of effect of that psychoperceptual type effect. Ketamine is not necessarily a bad option in this case. It's still reasonable. If the patient was opioid tolerant, or if there was any sort of respiratory concern, you might reach for ketamine. But this is one of those cases that fentanyl would be something that was very easy and reasonable to use. Rib fractures with COPD. So you have a 71-year-old male that fell down the stairs, severe right-sided chest pain and worsening shortness of breath. There's some rib fractures. Pain worsened significantly with inspiration. The patient also has a history of severe COPD, and we're looking at an SpO2 of about 91% on their HOMO2, and the patient is very anxious. So what are we thinking about here in terms of medication selection? So some of the advantages that ketamine might have in this case: less respiratory depression, preserves that respiratory drive, useful in pulmonary compromise, whereas fentanyl, on the other hand, can have that hypoventilation risk in a vulnerable respiratory patient. Okay, so anxiolysis during a BiPAP and a COPD exacerbation. So this patient is tripoding, tachypnic, anxious, repeatedly pulling at the BiPAP mask. Severe COPD history, 86%, but improving to 93% on BiPAP, and title is 58. Significant accessory muscle use and anxieties making BiPAP compliance difficult. So what would you be thinking about in this case here? So here's one that you have benefits of both. So the advantages of midazolam use would be anxiolysis, reduced panic and anxiety, and a familiar agent with BiPAP tolerance, but you would have to kind of balance those concerns of respiratory depression and hypoventilation in a hypercapnic COPD patient. Where ketamine kind of has some benefits here would be preserving that respiratory drive with the bronchodilation benefit, so it can improve BiPAP tolerance without significant respiratory suppression, so offering anxiolysis with less risk of worsening ventilation. Okay, and then severe agitation delirium. So you have a violent patient. They're shirtless, they're diaphoretic, screaming incoherently, actively fighting, extremely combative, unable to safely obtain vitals. I think everybody's probably on the same page with this one, the advantages of ketamine. So you have super rapid dissociative sedation, reliable control in severe agitation. The IM route is really useful, and it has the major point being really fast scene control. Concerns for midazolam here would be slower, reduced effectiveness in severe agitation cases, as well as higher risk of inadequate sedation as monotherapy for midazolam. When we're looking at a case that's more moderate agitation, so you have a 37-year-old female who's an agitated patient at a public event. She's crying, pacing, hyperventilating, but she still remains redirectable and follows commands. Vitals look fine. She's answering questions appropriately. Some alcohol use, but has a lot of severe anxiety, anxious and escalating emotionally, but she's not violent, no physical combativeness. So kind of what would be your approach there? Midazolam would be a great option, effective anxiolysis, useful for mild, moderate agitation. It avoids any sort of unnecessary dissociation. So for ketamine, it would likely be considered excessive probably for this presentation. So dissociation may not be necessary. So not every agitated patient requires dissociative sedation. So matching medication intensity to kind of patient presentation intensity matters. And then the last one we're going to talk through, whoops. Okay, there we go. Last one we're going to talk through is when ketamine may not be the best choice. So you 78-year-old male, you're called for crushing substernal chest pain radiating down the left arm. The patient is anxious and restless, feeling like he's going to die. Heart rate 128. he's hypertensive, you do an ECG, and it's an anterior STEMI. Patient is becoming panicked, difficulty remaining still for continued evaluation and transport. So what are our options here? So why ketamine might not be ideal. So again, that sympathetic stimulation, increase in heart rate, blood pressure, myocardial oxygen demand, that can potentially worsen cardiac workload during any sort of active ischemic event. So it's not automatically the best sedative in every EMS type scenario. So in this particular case, why midazolam would be preferred would be anxiolysis without that sympathetic stimulation, reducing catecholamine surge from anxiety and helping facilitate that calmer kind of transport and evaluation. So active MI, severe hypertension, or situations where any sort of increased cardiac demand is going to be a more dangerous situation using ketamine and would not be the preferred agent to use there. Okay. I know that was super rapid fire and talking really fast and everything. I apologize for that. I apologize for my technical difficulties, but if anybody has any questions that they were able to gather during that, I'm happy to take them.
Yeah, folks, feel free to put questions either into the chat or the Q&A. For some reason, one seems to work better for some folks than others. Are you able to see the chat, Morgan, or do you want me to read out any questions?
Let me see.
I can just read them to you if it's easy enough.
So there's one that says,
yeah.
Is there a reason we don't have an IM route option for ketamine regarding pain control? Yeah, so this is actually an interesting point. So there actually isn't great recommendations for pain control using IM administration. That lower dosing with pain control or with the anxiolysis and CPAP, that 0.4 mg per kg, it actually isn't something that I'm super familiar with doing. Completely, admittedly, I was a little. That was a new thing for me looking at the protocol, because studies have shown that that lower dosing for IM administration doesn't have those same analgesic type properties that that the IV administration does. Right. So anytime, the next question says for analgesia, if we're administering via the intranasal route in a 500 milligram vial using 0.25 mLs, what's the recommended saline to add to help atomize medication without affecting efficacy? So anytime you're using an atomizer, you have to add 0.1 mLs of saline. That in the top of an atomizer, where the kind of little arrow spongy part is, there's an extra 0.1 mLs of kind of dead space. So adding, you can either add saline, some people will prime it with saline, but drawing up an extra 0.1 mLs will help kind of get rid of that dead space and be able to use the whole dose for the patient. This one says, was there an age limit for ketamine administration? So technically there is not an age limit in terms of, manufacturing recommendations or anything like that for ketamine. The reason that protocols have an age limit for ketamine that's over 65 is just because the risk of emergence reactions and delirium and things like that post ketamine is actually higher in older adults. So in order to kind of mitigate those risks of age-related concerns, the protocols will cap them at 65. But technically, in other settings, there's not actually an age limit for ketamine administration. Regarding the last case study, what exactly was the justification for using ketamine on that patient? So the very last case study was when we would not be using ketamine. And that was because the patient is having chest pain and an active MI. And that's something that we wouldn't want to have, those increased sympathetic outflow type effects that come with the use of ketamine. So we actually wouldn't be using ketamine in those patients. Sorry if that was a little confusing.
Awesome. Well, thank you, Morgan, very much. I certainly got a bunch out of this myself too. Folks, there's a evaluation link in the chat. As always, put any comments there. That's also a space where you can put requests for future topics. I know Morgan's certainly very interested in the education stuff and working with our EMS group. So any future things that you want to hear about would be great. And yeah, otherwise, hope you all have a good rest of the day. Again, happy EMS week. Wednesday, if you're coming through the Maine Med ambulance bay, I have a barbecue going on near the ambulance bay, so grab some food for lunch on Wednesday. Or if you're around and want to just wander through, feel free to just wander by also. Yeah, with that, we'll end this out and hope everyone has a good rest of the day.